Lesser tubercle. Is the lesser tubercle more medial or more lateral? More medial, right? So more medial. So if we think about as I'm adducting and internally rotating, I am impinging that lesser tubercle on the coracoid process. So I'm basically narrowing the space. And so thereby I'm getting this impingement sign. So differentiating between the two is going to be area of pain, and then one is just inflection with internal rotation, which is your Hawkins-Kennedy, and then this one is your anterior impingement with internal. So that's your subcoracoid impingement. Okay, does everyone follow that? Veneers is you're just stabilizing the scapula and then taking the arm up and again creating an impingement sign. All right, and then your arc of pain is an active test where you're looking for that arc of pain between 80 and 120, 130 degrees of either flexion or abduction. Okay, all right. So those are your impingement, your external impingement tests. Okay, all right. The next ones are your biceps provocation test. So the speeds test. Let me have you stand up for me. So here, your arm is in a fully extended position, supinated position. You're going to add resistance, and you're going to have your patient basically go into shoulder flexion. So hold, and go ahead. I'm sorry, not hold, but go ahead and push into my hand. You're going to provide some resistance as they go up. So that's trying to activate the biceps tendon. Okay, so it's a provocation. It's a painful test. So it's not so much weakness, it's more provocation. With your Erickson's test, so this is looking at the transverse humeral ligament that stabilizes the biceps tendon in its groove. And so in some cases with people who have chronic biceps tendonitis, their biceps tendon may be subluxing out of their groove, and that's what this is testing for. So it can be painful, and you may feel a little bit of subluxation of the biceps tendon. So this is, the elbow is in 90 degrees of elbow flexion, arm is in supination. So Tricia, I want you to kind of push out and push your arm out, and then you're going to provide some resistance. So go ahead and do that, and you're just feeling, do you feel any subluxation or pain as she does that? So my finger's right on the groove there. Okay, so that's called the Erickson's test. All right, I'm going to go ahead and have a seat, Tricia. So the next are your rotator cuff tests for pathology. So we've already done some of these. We haven't already done, but we've done kind of a quick where we've looked at abduction, internal, external rotation, right, as part of our examination and clearing. So here's some other special tests. So there's the empty can, where you're in about 90 degrees of abduction in the scapular plane, and you're adding internal rotation. And typically, I'll do it both at the same time. And so here, hold, don't let me move you, and see, can I break them or cause any pain? The problem with this test is, what do you think? It might be pinched, right? So I'm internally rotating, so that may cause pain or discomfort on some people. So there's a modification where we can do what's called a full can, and have the thumb up. That way I'm clearing the greater tubercle away from the acromion, and same thing, hold, don't let me move you, and looking for any pain provocation. Okay. So there was some discussion with the other group, well, why do this one instead of this one? And I think Kelly said there was a study that because of the greater tubercle getting impinged, this may be a better way of doing this test. But the reason why I show the empty can is that it's kind of an old test, and it's known in the PT literature and in the clinic, so I wanted you to get a sense of what's the empty can versus the full can. Okay. The next one is your lateral rotation lag test. So this is looking at infraspinatus. So here you're taking the arm up, you are abducting and fully externally rotating. And then you're going to tell the patient, okay, I want you to hold this position. I'm going to let go, but I want you to try to hold this position for me, okay? All right. So you'll let go. And so Tricia has a negative test. A positive is when you let go is that her arm is going to go into internal rotation. Does that make sense why that would occur? Because here I'm having her hold her arm in abduction and external rotation. If her external rotators are compromised, if they're weak or compromised or there's a tear, she's going to have a little bit of what's called a lag sign where it's going to drift forward. She can't keep it at that end range externally rotated. Does that make sense to everyone? Yeah? So that's the lateral rotation lag test. The other one, let me have you standing. This is your Gerber liftoff test. So we have to turn around just to show them. So with this one, so typically we do subscapularis in this position. That hold, don't let me move you. But what is the problem with that potentially?
Compensating muscles.
What muscles?
Pecs, lats.
Yeah, so you got two big muscle groups, your pecs, your lats. Are they pretty strong muscles?
Yes.
Powerful internal rotators, adductors. So what is to say that that's not being active when you're testing that? So what you have the patient do is reach behind their back. So now you're putting it in a shortened position, the pecs and lats, and you ask them, can you lift off your back? So now that's inducing an internal rotation. So that's isolating a little bit more the subscap. Go ahead and do that again. And now you can ask them, hold, don't let me move you, in testing. Okay. Well, what's the problem with this test? Oh, great, another problem. Yeah, I mean, it could be, you know, they have capsular tightness, so they can't reach behind their back, or what is a big complaint with any shoulder issue? I can't reach behind my back, it hurts. So if that hurts, you can't really do the test. It compromises the test. So a modification is the belly press test. So here, you're going to put your hand in between your partner's hand, between the belly and their hand, and what you're going to have them do is push into your hand at the same time bringing their elbow forward. So go ahead and do that for me. And so you're feeling how much pressure. If they can't do it, if it's torn or compromised, they're not going to be able to bring that elbow forward, and it's going to feel very weak, like there's hardly any pressure into your hand. So that's a positive sign. Okay, so you do this if this is not comfortable for you. Okay, so those are your rotator cuff tests. All right, so now for some of your instability tests. Then have a seat. So this is your sulcus test. So this is looking at not so much provocation of pain, but looking at someone's laxity within their capsule, within their system. So how lax are they? So you're suspecting that they may be quite lax. So here you want to find the lateral edge of the acromion, and you're going to do an inferior glide. And so we know Tricia is quite lax. So you're feeling for, as you can see this is the edge of her acromion. I shouldn't really see that normally, but she's quite lax. So for her, that's normal. And you would check both sides to see if it's normal for that person. Okay. So it's not necessarily she's lax, but she doesn't have shoulder issues. But she doesn't have issues. So she has good control, but she has excessive movement. Okay. All right, so she's a perfect example of someone who's hypermobile, but it's not pathological. She has good control. Versus someone who's unstable, different story. Okay. So that's really just looking at how lax someone is. The other test, before I have you do that, let me have you stand, because I think I showed it standing, the O'Brien test in the other group. The O'Brien.
Oh, yes, we
Yeah.
did do that, yes.
Yep. So you could do this in sitting or standing, but I showed it in standing. So this is looking at superior labrum. All right. So here, what you're having your patient do is going into flexion, about 90 degrees, and about 10 to 15 degrees of adduction. And then they're going to go thumb down, internally rotate. You're going to ask them to hold here, don't let me move you. They'll say, ah, that hurts. Then you keep them in that same position. Now they're going to go thumb up. Same thing, hold, don't let me move you. That feels better. You okay?
Yeah,
Okay. So you're looking for it hurts, feels better. Okay, and that's a positive sign. Now, why is that? So, when we go into adduction and I go into internal rotation, what you can imagine is I'm putting stress, putting more strain on the biceps tendon, the long head of the biceps tendon. So if that labrum is compromised, it's going to pull on it. And therefore, I'm asking her to hold that position. It's going to stress the biceps as a shoulder flexor. It's also going to stress it even more, pull on it even more, thereby cause pain. When I take her out of that position, it's going to shorten up the biceps. So it's going to put less tension, thereby the pain should reduce or have no pain. Okay. Now, if it's pain in both, what it is, not sure. Okay. But you're looking for a change in the pain, less or gone. A big difference in pain. Go ahead and lie on your back. So that's the O'Brien's test. I went out of order, didn't I? I'm sorry. My brain. So that was a labral test. So looking at apprehension test. So this is looking at two things. So if someone dislocated anteriorly, they had a dislocation anteriorly. Let's say you're, maybe 6 to 8 weeks in their rehab. You want to see how well are they tolerating this position, because this is the most compromised position for them, right? So you take them into shoulder abduction. You're going to have your right hand right on top of their shoulder, and you're going to take them into external rotation. And what you're looking for with this is that the person may be apprehensive. There may be some point within their rotation that they get apprehensive. Then what you do is you apply an A to P, and they should feel better. In terms of their, that feels more secure, you may be able to go further into rotation. Okay, so that's for someone who has maybe a history of dislocation, subluxation anteriorly. Different scenario. Looking at internal impingement. So remember I talked about how with internal impingement, it's kind of end range pain, or in this position of abduction, external rotation, where they have that posterior shoulder pain, right? So the relocation test can be used where you take them into that end range of external rotation, and they may say, I have pain. I have pain back here. Yep, that reproduces my pain. Then you apply an A to P, and they say that feels better. So you're relocating the glenohumeral joint. Feels better, you can take them further into external rotation. So you're looking for that response of it feeling better, taking away the pain. Okay, does that make sense to everyone? So that's a way to help you diagnose internal impingement. Versus Hawkins-Kennedy, NEARS was more for external impingement tests. This one was more for subcoracoid impingement. Okay? So while this one is looking at internal impingement. Does that make sense to everyone?
So
That could be two.
or
Yeah. And usually with someone who has internal impingement, they have a stability issue. That's probably why they're having those problems, is that they have their little lax anteriorly, and thereby you're creating more stability. Versus the apprehension test, it's more of this apprehensiveness, that they feel like it's going to dislocate. So this is someone who has a history of dislocation. And this can be a nice way of testing someone as you're treating them maybe 6 weeks, 8 weeks, 12 weeks. How do they feel when they get into that position? You know, are they good? Are they less apprehensive? Is the joint becoming more stable? So it gives you a sense of when can I start strengthening them in this position versus just staying down here. Right? So we start down here, but we gotta work our way up top because this is where they're throwing or doing whatever activity. This is where they want to be stable. But when do I do that is the big $1,000,000 question. And so sometimes this can let us know. Are they still very apprehensive? Okay, you're not quite ready for it. Okay. So that's the apprehension test, relocation test. And then there's a posterior apprehension test. So we talked about how typically 95% it's always an anterior dislocation, but there are cases where it may be a posterior. And this is very similar to the mobilizations that we've done, doing an anterior to posterior to stretch the posterior capsule. And so with this one, slide towards the nutrition. Taking them into flexion, a little bit of adduction, internal rotation. You want to put your hand here, just so as you're applying an anterior to posterior force through the humerus, and seeing when you do that, are they apprehensive? Do they tighten up? Do they feel insecure? So your hand is here just to make sure, you know, does it sublux or dislocate if they're that vulnerable. Very rare though. I've never seen someone posterior. Have you?
Once or twice.
Once or twice.
More so anterior.
Yeah. Okay, so that's looking for posterior apprehension. All right. So those are our stability tests. The next one are your labral tests. So I showed you the active compression, so the O'Brien's test. So that one was looking at pain here versus not pain here. So that's looking at a slap lesion, looking at the superior labrum. Then there's a crank test. So here you're taking the patient into about 160 degrees of abduction, keeping the elbow at 90 degrees. Now you're adding a compression and doing internal and external rotation. So here you're looking for pain or any clicking or popping. Okay. So here, compress and doing internal external rotation. All right. Then we have the biceps load test is again another labral test. Here is abduction, forearm in a supinated position, and having them hold, don't let me move you. If you want to tension it even more, you can take them into external rotation, hold, don't let me move you. So again, we're stressing the biceps to stress the superior aspect of the labrum. So you're looking for pain provocation with this test. You can take them into further, so there's another biceps load 2 test. You don't have to worry about it, but just know that it's just taking the arm further into abduction and saying, hold, don't let me move you. So you can start in more of a neutral rotation or getting even more vigorous at end range external rotation. Because this is where typically people have the slap lesion is difficulty here or difficulty with the follow through in terms of where they're having their pain. So these tests are meant to mimic those positions. Okay? So that's the biceps load test. And then, is that it? That's it. And then we showed a manip to the glenohumeral joint. So this can be done on any shoulder that is hypomobile. Typically, I will do it a lot on posterior capsular tightness patient. So what that looks like is you want to stand on near the head side. You're going to use your shoulder to kind of create a counter force, and you're basically doing a distractive force at the GH joint. Pulling the shoulder this way. So I'm here, getting into a stride position, and I can just shift my body weight back. Okay, so I'm feeling when I start to get too arch. Okay, and then I might do a little mini thrust, see how that feels. Okay, do a couple. Okay, and it's just a little distraction. Okay, so this can be done to any hypomobile joint. That was it? Time to go home? Any questions with any of those?
You could again.
I don't think so. I can't. All right. So we will next week we can practice those. So practice them, and then we can practice them here again. You know, the elbow isn't too complex where it takes a lot of time. So we can definitely we'll have time to practice them. All right. Yes.
We have time to do this objective, sorry.
Oh, at some point.
Four.
Okay. There may be, it depends how fast we get through elbow and wrist. So there may be time at the end and we can go through a case. Or I think definitely you have your Therex assignment, and that there's usually about 20-25 minutes that we can practice then after that. So, yes?
And if not, can you at least give us the cases that you were going to give us so we can?
It was very open-ended.
Okay.
So when the cases that I gave was an internal impingement and a frozen shoulder case. And I left it kind of up to the patient to kind of make up the symptoms, so it gets the patient practicing on the presentation. So I wasn't very specific. I kind of left it very open-ended on the presentation. But you understanding presentation is a good way of practicing with each other of making sure you're giving the right information. All right. When you're practicing, what we saw with people is make sure that you go through everything you need to do in supine, do in supine. Everything you need to do in sitting, do in sitting. Standing, sitting, supine or sideline, and then prone. We saw some people kind of jump into prone to clear the neck. Don't want you to do that. We want you to go systematically so that you keep everything straight in your brain. Okay, what do I need to do in standing? What do I need to do in sitting, sideline, supine, and prone? That way you don't have the patient up and down, up and down. Okay, yes?
Are you particular about, like, when we're doing muscle testing, putting them in, like, gravity eliminating position and stuff like that, like we did in foundations last year? Is it more like if you want to test internal and external, like sitting, testing it here is okay?
Mm-hmm. I think it depends on what your thinking is, but I think the way we went through it is fine.
Okay.
But if you're trying to, I don't know, see just if someone can go against gravity, you could easily do that.
Okay.
Couldn't you? How would you do it if you're looking at rotation? Sideline. Okay. Can you do that? Okay. So I'm not necessarily looking at that, but if you're noticing, let's say you break someone pretty easily, and then your curiosity is, well, can they even go against gravity? And maybe get them on their side. Can you even do that? Can you even go against gravity? Because it seemed like they were very weak and painless, right? You were like, whoa. So how about here? Oh, I can only do that. Well, okay. What does that tell you, do you think? It could be neural, or what else?
Full tear.
A full tear. You know, somebody doing this, it could be a pretty bad tear in there that they can't even go against gravity. So I think it depends on the result. But if you want to do what you learn in foundations, by all means do. That's great. I have nothing against that. Bringing it all together.
for our class. So if you are practicing these special tests, I'll be in my office if you guys have any questions.
And so know that you don't have to do all these special tests as part of your shoulder exam. It's like the knee. You're going to do every special test on every patient that walks in. It's pointless. And then you're going to probably get a lot of false positives. Because what is your hypothesis, right? If I have an internal impingement person and they're having pain, well, maybe they may have a labral issue. So maybe I want to look at that slap lesion because of their arm position that may be causing or contributing to their instability in their shoulder joint. So that may justify it in looking at a relocation test. Okay, so depending on your patient presentation, those are what I want you to think about and focus on. So I don't want you to just blanketly memorize these. I mean, you have to, but when to apply them is going to be more appropriate because that's what they're made for, is to apply them to the right patient. Otherwise, you will get false positives. Yeah? I don't know if I want to go home. I'm sitting in traffic for hours. Look at it. Should I go now? Should I wait? It's waiting worse. What do I do, Megan? I don't know what to do. Do you think it's going to be worse if I wait? Is that what they're saying? It's going to freeze? Yeah. All right. Sorry about this, guys, but it's really, I asked Sky and she said, yeah, they really don't want, if we're closing by 4, they want everyone to be done by 4. So if something happens, somebody decides to break into the building, sorry, you're supposed to be closed. What are you doing in there? So, all right, guys, have a good weekend. If you have any questions,